early intervention with a triple therapy stop the progression from smoldering myeloma to actual myeloma? That's the question being addressed in a pair of phase 2 clinical trials being presented here at ASH 18. To talk about them, let me introduce you to Dr. Irene Ghobrial, who is an MD and an associate professor of medicine at Harvard Medical School and on staff at the Dana-Farber Cancer Institute. So this is the one you've just presented. The first one is elotuzumab plus lenalidomide and dexamethasone in high-risk smoldering multiple myeloma. This is a tough condition, correct?
Absolutely. Smoldering multiple myeloma is a condition, it's a precursor to multiple myeloma, and we know that almost all of the patients will progress in their lifetime. We just don't know who will progress very fast, what we call high-risk smoldering disease. And the important thing is, in general, all other cancers, when we see breast cancer or lung cancer, you never tell anyone, wait until you have metastases everywhere and then I treat you. Yet in multiple myeloma, we tell them, wait until you have fractures in your bones, lytic lesions, anemia, renal failure, and then I treat you. So we're starting now to say, why are we doing that? Why not treat them early? And by doing an early therapeutic intervention, can we potentially prevent progression or potentially even cure the disease at the early stages? And there are several clinical trials ongoing right now in those patients who have high risk, meaning that they will progress within 2 years, 50% chance of progression within 2 years. 2 of those studies we're presenting here in ASH. One of them is the combination of elotuzumab, lenalidomide, and dexamethasone, trying to really use the immune system or harness the immune system to attack the myeloma cells and prevent progression. And indeed, this was a 3-year follow-up, and we've shown that indeed those patients, 95% of them have a progression-free survival at 3 years time point. And this is exciting because we're showing already that you can prolong progression in patients with smoldering disease.
So what in terms of efficacy and safety are you looking at with this whole panoply of trials?
Absolutely. It's very important to balance safety, toxicity profile, and responses. And you want to use combinations of therapy that are safe, that would not cause major toxicity in our patients, and this is important, especially in a smoldering setting. And you want to say that indeed you're using something smart. Precision medicine is the new wave that we should be using in our patients. And that's why it's important not to try and do too many toxic therapies in those patients.
Well, you also examined whether genomic studies can help in determining patients who would benefit the most from this early therapeutic intervention. How did that go?
We're doing many studies, next-generation sequencing, as well as trying to profile the tumor microenvironment with single-cell RNA sequencing in those patients, because we know that not all smoldering myeloma is the same. And we know that the risk classification that we use right now is based on only clinical markers, the tumor burden, the M-spike, the light chain ratio. What we want is to, again, be smarter in the classification of our patients. Can a patient with a MAP kinase mutation be at a higher risk and therefore should be treated early? Can someone who has a MYC translocation or amplification be considered a high-risk smoldering myeloma, even if their numbers are not that high, and say, let's put them on a clinical trial? But also, can we be more precise in our therapy? Someone who has a 17p deletion or p53 mutation will not behave the same way, even at smoldering setting, and we need to be careful with those patients. So again, trying to understand the biology of the disease and trying to treat it or intercept it early is very important for us.